about 70 people that complete suicide are first-time attempters. So just know that the risk that goes in one direction only and is not protective. And the other kind of really important part about this is that all we can do is manage risk and try to reduce the person's risk. It is very, 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 very difficult, almost impossible, some people would argue, to prevent someone from committing suicide. All we can do is really manage risk factors. And I think I kind of already said this already, just to couch this discussion. We know that maternal mortality, that mental health conditions are a major driver of that. Next slide. And the data that I just showed you came from 36 maternal mortality review committees throughout the United States, but South Carolina was not included in that. So I just wanted to show some of our South Carolina data, which is also consistent with that. Roughly 20% in 2018 of deaths in women were in this period were related to mental health conditions. Next slide. And that should not surprise any of us, because mental health and substance use conditions are really common during pregnancy and the postpartum year. Roughly 1 in 5 women will experience this over the course of that time period. That works out to be about 11,400 women in South Carolina annually. Next slide. So that data, the most recent maternal mortality data, had some really important findings in terms of kind of leading causes of pregnancy-related death by race, with non-Hispanic Black persons, cardiac and coronary conditions being a leading cause, and Hispanic and non-Hispanic white persons, mental health being a leading cause, and non-Hispanic Asian persons with hemorrhage being a leading cause. And what I just wanted to point out with that, actually, if you go to the next slide, is that having a history of depression is actually an independent risk factor for cardiovascular disease. And if you have a cardiovascular event and you also are depressed, your outcome is going to be a lot worse than somebody that has a cardiovascular event and is without depression. So that's a whole nother talk in and of itself, but mental health problems during this time period are 2 to 3 times higher, particularly among Black women and women of color. And so that outcome of coronary disease being a primary driver of death in Black women, I think that there is a contributing factor of mental health in that as well. So some sort of good news from all these data: about 80% of deaths were determined to be preventable. That is good news, and there's a lot that we can do to prevent some of these deaths. So next slide. This was data that came out in February, and this was a much larger sample, about 12,000 maternal deaths over this longer time period, really highlighting that maternal deaths due to drug overdose, suicide, and homicide. And as you can see, that drug overdose has a lot to do with the opioid epidemic, and that really driving a lot of these deaths as well. So just this kind of parcels it out a little bit more. Next slide. So this was a group, including South Carolina, 14 state maternal mortality review committees determined that among the mental health related conditions and deaths, pregnancy-related deaths were attributable to mental health conditions. 100% of those were determined to be preventable by these maternal mortality review committees. And they are really preventable by better screening and identifying these issues, and using what we call SBIRT, that process of doing that screen, doing that assessment, using brief motivational interviewing to help women to get to the next step of treatment. And we'll be talking more about that in the next echo. But again, what we wanted to do first is, before we get into screening, make sure that people are comfortable with what's potentially the hardest outcome to deal with. So next slide. So the kind of screening of mental health conditions and asking people about suicide actually starts at the practice level in terms of kind of overall culture of the practice. You can go to the next slide. And so it's really important about how we talk with women about mental health during this time, how people in your practice talk about mental health. And really what we want to be able to communicate is that, look, these conditions are really common. They have a huge impact on your health and your child's health and development. We're going to monitor your mood and your anxiety and your well-being throughout pregnancy and the postpartum year, just like we're going to monitor your weight and your blood pressure throughout this time, really just to normalize this, and then also let them know, like, hey, if there's ever a problem, you're not alone, you're not to blame, and help's available. So this was my really lame attempt of making an acronym, be kind. I know that if the I follows a C, it's an S, but anyway, we're just going to kind of go with it today. So you're kind of setting that tone before even asking about questions of depression. And the best way to ask questions about depression is actually using these standardized rating scales, Edinburgh Postnatal Depression Scale, and the PHQ-9, really because that will ensure that you are asking these questions consistently across every single patient. And they're good evidence-based scales that do a good job of picking up on these conditions. Both of them have questions about suicide ideation, so you'd already have that information in front of you before you would talk to the patient. So there's also, if someone's endorsing suicide ideation, there are some really great scales. The Columbia Severity Suicide Rating Scale is a really great one. That can be done by the patient, but it also is a good guide for a provider. The questions that they ask in that is exactly what you want to be asking the patient. So whether you're using the scale or you're just using that scale as a guide, that's a really appropriate way to assess for suicide. And so I'm just going to walk through each of these and kind of how we ask these questions. So if you go to the next slide. So again, I've talked to this woman, she's telling me she's not doing well. And I kind of reflect back to her exactly what she's just said, and that I'm sorry that things aren't going well. And I would say something along the lines of, when people are feeling this badly, it's really common that people have ideas about, look, I just want to go to sleep and not wake up. Or if I got hit by a bus today, that would be okay. And asking them, is that something that you're experiencing right now? And that's what Dr. Monter talked about, just really the passive suicide ideation. This isn't something that they're going to act on, but they're just these thoughts that they're having, which are really consistent with major depression. So then if they say, yes, that's something that's happening, I would follow up with asking, well, what have you had any thoughts about killing yourself? And what I'm trying to get there is just any kind of specific ideas about killing themselves and what sort of things that they have been thinking about. The next thing I'd want to know is just their intent. Is this something that you feel like you want to act on, or that you're going to act on, or you're preparing to act on? And as Dr. King pointed out, what you really want to elicit there is why, what are the contributing factors, but really important, why not? Why have you not acted on these thoughts? Because that really tells me what's protecting this person. And I'm looking to see, are those protections, are they static or are they dynamic? Meaning that a static protection is suicide's completely against my religion, or it is, I would never do that to my family, or something that's a little more dynamic is, well, gosh, if I get that job, then next week, then everything's going to be okay. So that's not a stable risk factor or protective factor. So once I have that information, I'm asking about their plans. So in terms of your thoughts of harming yourself, have you started kind of working out how you would do that? And anything that they've done to prepare for that. So stockpiling medications, picking out a bridge, kind of thinking, getting the gun out of the safe, or keeping that gun loaded, or just whatever it is. Like, have they started preparing to kind of put that plan more into action? One major caveat. So someone is endorsing any sort of suicidal ideation, whether it's passive or active, is that you want to keep in the mind the differential diagnosis, particularly for pregnant and postpartum women. So obviously our mood disorders and psychosis. Sorry, Rachel, did you want to say something? No, okay, good. What you really want to differentiate suicidal thoughts from a major depression versus obsessive compulsive disorder, because when women have obsessive compulsive disorder, these are not suicidal thoughts. These are typically intrusive, distressing thoughts that come out of nowhere. It's not in line with what this person believes or thinks. They're really upset by these thoughts because it's not something that they'd ever act on. And for whatever reason, they can't control them. They can't suppress them. So these thoughts can be really disturbing. It can be taking a knife and stabbing your pregnant belly. It could be taking a knife and stabbing your infant, or it could be just, I want to die, or something that sounds very distressing to us. But in the end of the day, What it is it's about obsessive compulsive disorder. And these are thoughts that the person's not going to act on. They do not want to put any of that plan in action. Actually, they want help making them stop. And they often feel like, I can't tell anyone about these thoughts because they're crazy and somebody's going to put me in the emergency department. And so really important that as clinicians, we're differentiating between thoughts that are passive or active suicide ideation versus thoughts that are intrusive, distressing, not in line with what I believe, and I can't control them. Two different things. So if they're having more of a postpartum OCD picture, we can actually get them well with outpatient treatment. Therapy is really good, and our SSRIs that are the most serotonergic is kind of what we go with. Next slide. Okay, so now what do we do with this information? If someone's having passive SI, wish to be dead, this is probably a mood disorder. We're going to get them to treatment and resources, and we're going to do, just as Dr. Monter did, plan for what's, and Dr. King, what do we do if this gets worse? What's the plan? Who are we going to call? What are we going to put into action if this does progress? But with passive SI, these are kind of our go-to. So Postpartum Support International, they can actually, there's a 24/7, 365 days a week, women can call this hotline, pregnant postpartum women. There is a counselor that is available to talk with them by phone or by text. And they can actually also help them find a local provider. PSI, if you go on their website, you can actually type in a zip code where you're looking for a perinatal mental health provider and find one. I'm going to talk about Mom's Impact in a second, and also Postpartum Support Charleston, which is a local peer support organization. So this is the Postpartum Support International. Again, this is available to pregnant and postpartum women 24 hours a day, 7 days a week. Next slide. Always good to remind people about the suicide hotline. 988 is the new number. Again, available 24 hours a day, 7 days a week. Next slide. And if you're putting a list of resources together for patients in general, if you just have this as part of a packet for a practice, I would always include the domestic violence hotline in our local My Sister's House. Next slide. I'm going to tell you really briefly about Mom's Impact. This is another resource for any provider in the state of South Carolina that's working with a pregnant or postpartum woman. Next slide. The way this works is women can refer themselves, or you as a provider can refer them. They're going to talk to a care coordinator, just as Courtney talked about, do that assessment. And if needed, they can actually see a provider that day via telemedicine. Next slide. We also enroll women in this into what's called Listening to Women. It is a text message-based screening system that's been on pause for a little bit, but it was something that we'll probably pick up again as we move along. And this is just something that is going to help monitor that woman over time, make sure symptoms are getting better. And if she kind of falls out of treatment, at least we have a pulse on how she's doing and can get back in touch with her. Next slide. So practices, hospitals, organizations, any sort of providers that are working with pregnant and postpartum women are, they are eligible to get trainings for us tailored to your practice, whatever is most helpful. Next slide. And you can also call us anytime. So we're happy to get a call from somebody who's seeing a woman and saying, hey, I'm just not sure the diagnosis here. I'm not sure on next steps. You would talk to one of us and we'd help you through that process and management. So that's Mom's Impact. Next slide. These are just flyers. We'll send those to Rachel about how people kind of get in contact. You can make referrals online as well. Next slide. And this is the provider flyer. So Postpartum Support Charleston is an amazing organization in our community that is providing peer support. So women that have lived experience of perinatal mental health issues that are now wanting to, they're recovered, doing well, and they want to support other women. And so this is exactly what they do. So this is a great organization to connect your patient to so that they can talk to other moms that have been through something similar. And it really helps does a lot in terms of women not feeling so alone, not feeling like they are different, and knowing that there's help available and support available. Next slide. So now getting more into active SI and intent and or a plan, you really don't want to be sitting alone with this. You want to grab people in your practice that are going to help you. First of all, you really want to be able to ask that patient if you can get in touch with a family member, sometimes bringing a trusted family member into the mix to create a safety plan, making sure that person's being monitored, or if things get worse, how do we get this person to treatment, making sure that you're removing any potential means from the home, just as a temporary until this passes, and coming up with a plan so that that this person is kept safe until treatment can take hold or this feeling passes. And unfortunately, sometimes that has to be in a hospital if you can't create a plan that's going to keep that person safe at home. What psychiatric hospitalization more or less does these days is actually just put people in an environment where there is no access until the intent and desire passes. These are a couple of other mobile crisis I just wanted to mention. This is available throughout South Carolina through the Department of Mental Health. Say if you had a patient in your practice, they were endorsing some SI, you're getting the team together to make a plan and they leave and you don't get to make a plan. This is a great resource. You can call them. They will actually go out to that person's house. They will do an assessment with them and they'll figure out what they need. So there's lots of different places where you could employ this. Say you even just got a call from a patient and you were concerned. You could call this number. You could let them know what is going on. You have to give them an address, obviously, but they will go out and do a mental health assessment of that person, which is a fantastic resource. So just in summary, I know we only have a few minutes left. Just again, I think we've said all of this. I really just want to make sure that we address any questions that anyone may have.
Thank you so much, Connie. That was great. I think this is an area that we're all a bit nervous about dealing with, because honestly, when you